0.3% of all participants, but it did represent 30% of all resections. One of the other things that the Nelson trial has been teaching us is this idea of attached nodules, that if a nodule is attached to a fissure or a peripheral pleural surface, it's much less likely to be a lung cancer. And in fact, all of their cancers to date have arisen within nodules that are within the lung parenchyma, so surrounded by lung. They concluded that 1-year follow-up CT would be sufficient for any smooth or attached nodules, even if they're over 5 millimeters. And I'm sure these are very familiar to you. Oftentimes when they're resected, they turn out to be intrapulmonary lymph nodes or small non-calcified granulomas. The other thing about density that we're learning is this concept of concern for ground glass and part solid nodules. We know from Claudia Hinchke in their group that this part solid nodule, a nodule that has both ground glass and solid elements, was by far the most likely to represent a lung cancer in their trial. And in fact, these subsolid nodules, either ground glass or solid, represented a large percentage of the malignancies in the LCAP trial and were mostly bronchoalveolar or adeno with BAC subtypes. We know we have trouble measuring small nodules when we're using our typical bidirectional measurements. And in fact, this is an example from the LCAP study where it was very difficult visually to determine whether a nodule had grown or not. And it really wasn't until these volumetrics were done that it was evident that the nodule had in fact grown, but mostly in the z-axis. We know also from screening data that we're going to have to follow the ground glass and part solid nodules at wider and longer intervals because their doubling time is so much longer than that for the solid nodules. Solid nodule that's a lung cancer, doubling time a little over 100 days, whereas a pure ground glass nodule over 800 days. I'll talk briefly about the adenocarcinoma bias. We know that most of the lung cancers we're detecting by CT are adenocarcinomas, and I think some type of combination with sputum assessment would help to ensure that we're getting more of the full spectrum of lung cancer detection. I'll briefly mention missed lung cancer. It's surprising that, or not so surprising, given that the results in daily practice also show that despite the fact we tend to detect one or more small nodules in over half of participants, we also miss nodules. The LCAP had a 22% miss rate, and the Mayo Clinic had about a 26% miss rate. When looking retrospectively at missed lung cancers in a Japanese screening program, it was interesting to see that some of these lesions, although fairly subtle at the time of initial miss, were still missed even when they were getting a little bit bigger. This one was missed for up to 2 years, but was still a stage 1A at the time of diagnosis. So computer-aided detection is really going to be a helpful tool to radiologists to make sure that we don't miss as many of those nodules. Some sites are also doing things with these multiplanar reformation, maximal intensity images that really have the nodule sort of light up like a light bulb for you. The last thing that I'll mention in closing is this concept of potential overdiagnosis. And I think you're probably aware that this refers to disease that would have remained subclinical if not detected at screening, and disease for which autopsy prevalence is higher than the clinical prevalence of disease. Some people think that lung cancer could not ever be overdiagnosed, that it's such a different animal than other cancers, and there are others who say that it's not that different, that there is a potential for overdiagnosis. It's interesting to look at the Mayo data. In 48 cancers detected in their screening trial, the mean doubling time was over 500 days, and those who had the longest doubling time were mostly women. And I think there is some potential concern based on their data about overdiagnosis in women of bronchoalveolar cell type of cancers. Further studies necessary. This image here shows a patient who in 2001 in the upper left had a nodule detected that was recommended for follow-up, but somehow the patient was lost to follow-up. In the middle slide, she comes back 3 years later, and the nodule's grown a little bit, but she has an absolutely brand new larger cancer in the left lower lobe. And when we see her again, just 1 month later, she gets a PET CT, and the SUV of the right upper lobe lesion is 3, whereas the SUV of the left lower lobe lesion is 17. So even in one individual, you can have lung cancers develop that have very different biological activity. This was a humbling experience for me and a screening participant. 2003, completely negative scan. 2004, a spiculated nodule. I was very concerned about the possibility of lung cancer. She underwent a PET that was negative. I think a very judicious decision was made to biopsy that. The biopsy was negative but non-diagnostic. Followed closely in another couple of months, and it went away altogether. So in summary, I think there are a number of challenges for lung cancer screening, but I think we are definitely at a point where we're really meeting those challenges. I think in terms of whether screening reduces lung cancer mortality, we'll still need to answer who should be screened, who will pay, and what is the role of other emerging methods. And I would like to emphasize in my very closing slide here, we're already screening. Day in and day out as a radiologist with increased CT utilization, I'm looking for small lung cancers on every scan. And all of the data that's been learned and shared from the trials to date, including the LCAP study, the Nelson trial, are informing my daily practice in terms of which nodules to follow, how to follow them, and which ones go to surgery. I'm cautiously optimistic that the results of NLST and Nelson will produce the type of data that we need to make lung cancer screening available in a more formal way, but I think we owe a great deal of debt to these studies regardless of their eventual outcome, because they really are informing our practice and helping us to detect lung cancer on scans in daily practice. Thank you very much for your attention.